Okay, the question is, how long is imatinib funded for the government?
Okay. So imatinib was approved by NICE for metastatic GIST back in 2004. And that's as long as you keep responding, you get the imatinib in the metastatic disease.
Does that go on, let's say somebody takes it for 8 years?
Doesn't matter. If your GIST is responding to treatment, if you got metastatic disease, meaning that secondary cells were, or the tumor was initially inoperable and the surgeon couldn't have done an operation, and if you're on imatinib, you stay on imatinib as long as you are tolerating it, as long as the disease is responding. There's no time limit on that imatinib. There are some patients who may want to come off imatinib after 10 years. I wouldn't advise that. Imatinib in the long term has got very few serious side effects, 1 or 2 which we're concerned about, but nothing major. In the adjuvant setting, meaning when the tumor has been removed, the primary tumor has been removed, there's no evidence of spread, the NICE has made a decision based on the trials that is 3 years of adjuvant treatment after the primary GIST has been removed. Right now, that's a standard of care everywhere in the world. For patients with a very high risk of GIST coming back, you get 3 years of imatinib. The caveat to that is it is mandatory, I'm going to use that word again, mandatory, that you should have your GIST mutation analysis tested before you start the 3-year treatment. We're doing a trial at the moment, 3 versus 5 years, so that trial will take probably another 2-3 years to complete, and we'd have some data 7-8 years down the line whether 5 years for a select group of patients would be beneficial compared to 3 years. So right now, 3 years after the operation, if it's metastatic disease, as long as you keep responding, as long as you keep tolerating.
Just to add to that, Ramesh mentioned that NICE have added an adjuvant treatment. Now, I didn't know what adjuvant meant before I joined this, so for those that don't know what that means, and if everybody knows... Yeah, okay, but adjuvant means a treatment when the GIST has been removed, margins are clear, but there's a high chance of it coming back. They treat you with imatinib to try and prevent any disease from, or treating a disease. So, right, he's going to talk about that. Now, as a charity, in order for NICE to approve it, they have to have a session, which is quite an in-depth session, which GIST support and myself and one of my colleagues went to as a patient expert to give a patient perspective as part of their decision-making process. The reason I'm telling you this is that this isn't all that we do with GIST Support UK. We do help with things like the NICE appraisals in order to get more drugs to be able to be used by clinicians to treat GISTs. So that's one of the arms that we follow quite extensively. Right, another question. Yes. Sorry. All right, you can do it. Yeah.
I don't need it, but they might not.
Yeah, they won't hear it there.
Regarding imatinib and Glivec, the last time I went to collect my prescription, they tried to substitute it with a generic Glivec. What's the thoughts between the Glivec and a generic one? I did get the Glivec in the end, and that's fine, but they're trying to substitute.
Right. Take a deep breath. So what has happened is imatinib has got 2 patents. One is the patent for chronic myeloid leukemia, which is a type of blood cancer. And that patent ran out about 2 years ago, I think, in Europe. And there's a separate patent for imatinib Glivec for GIST, which has not actually run out as yet. But lots of hospitals in mainland Europe have already substituted Glivec for generic imatinib. Like, for example, you take Calpol, paracetamol, both are the same compound, but Calpol is a brand name, paracetamol is a generic. The difference in imatinib is imatinib tablets, Novartis, Glivec is tablet, whereas these ones are capsules. That's the first difference you notice. And these generic imatinib tablets have gone through the same stringent quality assurance programs. The feedback we had from the European Medicines Agency is that they're kosher. Their quality is as good as imatinib. There are some anxieties about generic substitutions in the medical community, not just oncology, but in the medical community. The best examples are patients who got, say, epilepsy, seizures long-term, or patients on medications who long-term medication suddenly switch from one brand to other brand. Sometimes somehow the availability of the drug into the body seems to go down or go up. So that's one of the anxieties about switching from one brand to other brand. But what is driving the switch from Gleevec to generic imatinib is cost. So that's what bottom line is. It's the cost of generic drugs are almost always they're actually lower than the. So the patent has not run out as yet for just Gleevec. It has run out for CML, but the countries as a whole in Europe have already made the decision they're going to switch. What we know so far is that if you take 400 milligrams of the Gleevec, 400 milligrams of imatinib generic, the blood levels are going to be very similar. So that's what we know. Only time will tell whether that's actually true, but the tests have already been done. The work has already been done for the generic imatinib. One of the anxieties is, can you trust the companies who are making generic imatinib? Well, Novartis has got a huge reputation behind it. And if you got somebody making imatinib in the backyard in Timbuktu, would you trust it? As long as the commissioners source it from a reputable company which makes generic imatinib or generic any drug, that should be fine in Europe. Some anxieties about where it's coming from. For example, if it's coming from a backyard in Hyderabad, I'm a bit worried about that. But it seems to be safe. There will be some bioavailability problems, and some people may get higher levels of imatinib, some people may get lower, but we can't predict that.
I think
Judith.
How do I? Right, it is working. I think there's a psychological effect here. The patient feels safe with Gleevec. You've taken it for some time, it's working, you're happy. So to change the packet or the appearance of the drug you're taking, I think there's a big psychological effect there, even if it's the same drug. I mean, I never buy Calpol or any of these fancy forms of paracetamol. I think it's a total waste of money. Paracetamol's fine, it's a fraction of the price, and it works effectively just the same. I suspect with imatinib it's very similar. There is a psychological effect, and I think we've just got to get over that. It is much cheaper. The legal side of it, I leave to the experts.
I can speak with some experience in this area with my other hat on, which is my transplant hat, where the same thing has happened with anti-rejection medications, where the equivalent of Gleevec anti-rejection medication lost its patent, and generic companies came in and made an equivalent drug. And we had similar discussions 5 years ago in the transplant community with patients worried about coming off their Calpol and going on to their Sainsbury's Basic paracetamol equivalent. And it's for a similar reason. And, there's the same anxieties around anti-rejection medication for your transplant as your cancer treatment. In the transplant community, 5 years down the line, I don't think there's been any issues with the conversion from branded to generic. So I can understand the anxieties, but it's obviously a very regulated area, and I wouldn't be too concerned about it.
Okay, I didn't mention Judith, by the way, as our Honourable President, Life President, and the founder of Just Support UK. So just in case you didn't know, that's who she is. Have we got any questions, surgically speaking? Jolly good.
Yeah, good morning. I'll try and keep it brief, but it's obviously difficult because this has been going on. My wife actually is suffering from GIST. She was diagnosed back in 2012. It was only through incidental that she was found. She had removed quite a large tumour. She was given a colostomy bag at the time 2 years later, 2 years later, she was on Glyvec with good response. She had a reversal because she had a Hartman at the time. All things going well, and then she had a regular CT scans, and her tumour was apparent to start to come back. So at this time we come from a small town in Lincolnshire, attached to the Grimsby Hospital. They didn't believe they had the expertise with regards to the ongoing treatment of the GIST. We were transferred to Hull. We're still not sure now whether that is still the right place to go. Our oncologist does assure us that he does talk to the MDTs. And Dr. Bozes, yes.
He's part of something we have in Leeds is we have a lot of patients coming from Hull, and so they come into our MDT on video conference, and that may well happen in other units where the other bigger centres in the area feed into the MDT. Yeah, so Dr. Bozes, he's involved in discussions.
Okay, so I've got
week.
obviously some confidence now that obviously he's related, because obviously trying to find out without hurting anyone's feelings with regards to that, because obviously I need to do the best for Rosemary. So it's just, where I'm leading to from a surgical perspective, that tumour was quite small at the time, and she went to see a surgeon across at Hull when she was transferred. That surgeon said, we're going to give the imatinib or another drug a chance to work. She was put on Sutent at the time, a different drug. She suffered quite bad side effects. Didn't really get on a reduced dose, didn't really get any response from it, and then a number of other tumours started to grow, so it started to spread. I understand that obviously within the stomach and other areas are now just being diagnosed that through a latest CT scan, there's now spread to the liver. Now, where I'm coming from, we've always asked the question, why can we not have these surgically removed? We were told that they weren't resectable, and there's been other tumours coming along. Now, what has been told to us is that you're saying, well, what's the point of going in and doing invasive surgery to remove tumours that can be removed and not the ones that can't? Now, it's hard to get a head around that, because the ones that are maybe possibly removed now could be in a position where they could be removed that may have caused problems later on, if you know what I mean. And the ones that are larger maybe just sitting there not doing any harm. So I suppose the question is, why would you have that notion to just say to the patient, well, we'll just, and I think it's basically saying on palliative reasons, if there's a complication, we'll operate, or a symptom. That's what we were told. We will only operate on the symptom, not the actual GIST itself. So that's what really questions, because why do we have? We're actually now onto a fourth line trial drug on compassionate grounds, not through a trial, because Rosemary's been through now regorafenib and was working for a short period of time, and that's now because it's now spread to the liver.
Yeah.
So I suppose the question is about. I understand what I'm saying. Okay.
So whenever we talk to someone about an operation, or we in our heads are thinking about an operation, it's always that balance between what good am I going to do for this patient versus what are the potential risks of doing that operation. And sometimes it's very, very clear. If you've got someone who's got a 1 centimetre GIST that you can do with keyhole surgery and just make a stomach samosa, then benefits very high, risks very low. The other extreme is, this is potentially a very, very big operation with a risk of major complications that is going to take this person 3 to 6 months to get over. They might even die as a result of complications of the operation. And I see that situation. I'm sure Jez sees that situation. And then you have to say, well, if I think that there's potentially a lot of benefit from taking those risks, then it might be something worth taking on. And then there's the grey area, which is often the hardest decisions and discussions for us to have with patients. So that's a sort of bit of a background. The difficulty with metastatic GIST, where you've got a lot of areas that are, and you've got new areas appearing despite trying lots of different treatment, is it's almost like weeds, you know, and it's an analogy in the garden. You can go in and you can take all the weeds, and then you come back a week later and there's more weeds. And not trying to make light of it, but metastatic GIST can be like that. We can only see, when we go in, what you can see with the naked eye. But it can be the case that there are microscopic cancer cells all over someone's abdomen or all through their liver that we can't see. So you could go in and take everything that you could see, and you would still be leaving cancer cells behind. And one of the things that we know is actually doing an operation can actually stimulate growth of cancer cells. So you go in and you do an operation, your body responds to that operation by producing a whole load of chemicals, growth hormones and things like that. And then that can actually encourage those cancer cells that you've left behind to grow even faster. So you can go in and remove what you can see, and then you actually make the situation much worse. And we see that particularly in the liver, because for the liver to regrow like we see it, there's a huge amount of chemicals that are produced in the liver, basically saying to all the liver cells, grow. But that also says to the cancer cells, grow.
Would that happen with ablation as well?
That question was, would that happen with ablation as well?
So, yes, but to a lesser extent. Because, you know, an ablation, it's a 3 centimetre or so area that's being affected. You know, with a big operation, even from just cutting someone open, that's enough of a stimulus because the wound has to heal. So less so with ablation and less so with keyhole surgery than with major surgery. So it's almost, the bigger the operation, the bigger that stimulation.
Can I just make 2 points about that quickly? Going back to what you were saying about your case, I think it's difficult for us to specifically comment on your wife, I think. But all I would say is that multidisciplinary team decisions sometimes change with time. So as events occur, you know, you can have a cancer that seems operable at one discussion, and then it can become inoperable. And then the other thing is it can be operable at one discussion and then become inoperable. So it's important to see what the multidisciplinary team is recommending, you know, at different points, because things can change. And it's important if there are new scans or new symptoms that there is a reappraisal of the situation. And then the second thing I want to say is that when you're in your clinic in you know, your local hospital, you might be talking to a gastroenterologist, you might be talking to a medical oncologist, you might not be talking to the surgeon. And sometimes if you hear feedback from a multidisciplinary discussion that someone says it isn't operable, it's sometimes difficult to take that from someone who isn't a surgeon. And we do sometimes get people who want to talk to us, to hear it from us, what the operability is, because they can't quite believe it themselves, or they're not, you know, they're just not convinced that it isn't. And then, so that sometimes it does help to come and talk to the surgeon, you know, in Leeds or wherever, to just hear what the facts are and what the risks are, because you know, at the end of the day, it isn't operable. You just need to be convinced of the arguments against having surgery, because people think it's not in your best interest.
We have in the past had patients who have sought a second opinion.
Yeah, and that's the other thing
and
I was going to say.
a new pair of eyes with different experiences, and on odd occasions we've had patients who've sought that second opinion. So one I'm thinking of is Michael Sayers in particular. He had liver metastases, and he was told they were inoperable. And so he sought a liver specialist who viewed it, and having viewed it and said, well, it's tricky. However, the advice I would give you is if you were my brother, I would be advising you to let me take it out, because I believe I can do it. So he went with that, and it was a success in that case. So it's always advisable to seek possibly a second opinion. Just satisfy yourself that you've got everything you need.
On that note, as a surgeon, I have had patients who have asked for second opinions. I had one chap who, I mean, it wasn't a second opinion from a surgical perspective, but he had a very rare type of sarcoma that we resected. And we, for example, said we didn't think any chemotherapy or radiotherapy was justified. He wanted a second opinion. He said, is it all right if I get a second opinion on this? We said, absolutely. And he consulted experts in America and over in Europe, and they agreed. And I think, that put his mind to rest, that yes, he'd explored it. And I think as patients, I suspect you kind of feel bad asking for a second opinion, and that you're questioning the competence of the surgeon. I personally wouldn't be offended if somebody asked for a second opinion, and I'm sure Jeremy would feel the same. So don't feel like you shouldn't ask for a second opinion. And it may be, I think in all likelihood is, the second opinion will often be the same as the first opinion. But then from your perspective, I would have thought that would give you reassurance that, okay, fine, I've explored the options.
And you have to remember that this is a rare disease,
Yeah.
and there are experts in this rare disease in this country, and the chances are, unless you're speaking to one of those experts, there will be somebody with more expertise that will be able to give you, back up the decision that's made, or maybe not. So yes, absolutely.
Just a couple of comments about second opinions. Firstly, I mean, that's fine, but they do take time to organise. So if you are asking for a second opinion in another hospital or another region, it can take weeks for your information to actually get there. It can even take a month for your scans, your pathology, everything to be transferred across to them to get it in place to discuss it at their meeting.
Relatively straightforward. If, for argument's sake,
Yeah.
I spoke to the oncologist and said I would like to have an opinion directly from the surgical team. It's just for that reassurance.
The other thing is that if you go for a second opinion and the second opinion is quite different from your first opinion, the second opinion you will need to go to your second opinion team for their treatment.
In our case, I was just basically having that discussion with the actual surgeons rather than through the oncologist. Who,
On a personal perspective, because you're essentially a Leeds patient, if you want me to sit down and go through everything and your history, and you want to see me in a clinical capacity, then just ask Dr. Bozes to write to me, and that would be fine.
I've already set that trap. I said to him to grab you before you leave. So.
Can I just comment on that from another patient perspective? If patients contact us on the phone line or by email and they are nervous about getting a second opinion, I don't want to offend Mr. So-and-so, he's so nice, he's been so good to me, I don't want to upset him. I say, look, if you get a second opinion and it's different from what he says, then he learns something too. So it's not a negative response. It's actually, well, perhaps I need to think about this again. We're all learning. And even the experts don't know it all. And I think if you get two experts together, they will often have different opinions, and they will learn from each other by batting ideas around. So it's
just an
it's
opinion
a positive.
at the end of the day.
Yes, that's
it's
right.
It's an opinion. It's
Yes.
It's not the law.
Yeah.
Another question here, then we'll go towards the back.
Hi. So I was diagnosed in 2007 through an ulcer rupturing. So I was gist free, I suppose, in my head for 4 years, and then it came back in my liver. And I'm well-type gist. And I've been on regorafenib. I've had Sutent regorafenib now for about 4.5 years. It's working on some of them, but not all of them. So my question is, and I am that person with the peppering, weeding, and I actually support that. I would only want to go through surgery if it was absolutely essential, or I actually thought it was going to benefit for me. But my question is there any research being done going forward? Because in my head, I think, in the future there's going to be for other treatments going to come up, but it's a question of timing for me. So is regorafenib going to last long enough that I then go on to whatever may be the next drug in the future? So my question is there ever any time or any research being done to sort of, in my head, because I'm not a surgeon, to just kind of clap the blood supply of the tumours, to give you that time going forward, particularly for your larger tumours, so the ones that perhaps aren't responding to drug?
So you can do that now. You can do what we call embolization of tumours, which is where you do exactly that. So you go in and you find the feeding blood vessel in the liver, and either inject some glue into that or put some coils into that. You can either, not necessarily in gist, but other settings, inject chemotherapy directly into the tumour and then embolize it. So the technology exists. Like all these things, it sounds lovely in principle, and then when you actually come to the practicalities of it, it's more complex, because you need to have the suitability of a tumour for that is very, very precise. You need to have a single feeding vessel that you can get to, that's not one of the main blood vessels that's supplying a lot of the liver around it. It's usually only used for one metastasis. With lots of metastasis, technically going in and blocking the blood supply to lots is higher risk. And particularly, it's almost the same as with the microwave. If you do it with a big tumour and you get that tumour's then going to die inside your liver, you've essentially got an area of dead liver. And then there's a risk of that getting infected, and then you have an abscess in your liver. So yes, the technology's there, and there is research being done, as with all things, to try and improve the technique. But it does have its drawbacks.
It's more difficult around the stomach.
Yeah.
Stomach's not really that suitable. There's too many blood vessels from different areas. Hard to target one, and you get collateral damage to normal stomach if you're not careful. So bit more, it's a good idea. It sounds like a good idea. I'm sure things like more targeted treatments from novel approaches to targeting the tumours are going to come along, but that type of thing is tricky with the stomach, more so perhaps than the liver.
Ramesh, are you going to talk about this afternoon fourth line and trials a little bit?
No, but I'm happy to.
Because that's the next, another step.
Just want to make a few comments about Rosemary. Very sorry that actually you're struggling with the disease. There are options available, but the important thing for you is make sure. Where was the primary gist again? Where was the tumour?
The original one was in the large bowel, I think. At the time, we weren't really.
Right.
If you'd had a Hartman's the original operation, so
must be the
sigmoid colon.
Now it's in the stomach,
okay.
and in other.
What drug you're on right now?
Regorafenib.
Regorafenib. Okay.
But I'm only I'm waiting to go on the fourth line drug.
Blue.
A trial.
Evapritinib? Right, okay. I think the important thing for you is if you want to be certain that you actually explored every option, we are very happy with second, third opinions. I send patients to other colleagues to make sure that I'm not missing out on any small things which I missed. And also people come to me for a second, third, fourth opinion. So we're quite comfortable with that kind of a thing. Nobody feels offended, okay? So if you feel that yes, you need another opinion, just ask for it. Just request. Absolutely no problems. Absolutely no problems. I got two things in my office. It's Latin, but I look at them every day before I start my first patient. The two phrases in Latin. The first one is primum non nocere. First, no harm. Nocere means pain. Second is secundum succurrere, meaning sugar. Succurre means sugar. Secundum means try and make it sweeter, meaning help the patient. But first rule trumps over the second rule, always.
Yeah. Do no harm.
Everything is resectable. My surgeons say, I can take it out, but is it in the best interest of the patient to take these things out? Because if you put the patient through a major multi-organ resection and they take 6 to 9 months to recover, and their life expectancy is 6 to 9 months, you haven't done any favor. So we need to be very, very, very careful. We have our local surgeons, we've got a very good GI in Cambridge. Our local surgeons backed off with one of my patients. Patient had a large stomach cyst, stuck to the pancreas, stuck to the spleen, and it was open and closed 5 years ago. Patient had been on imatinib for a long time, for 2-3 years, and then it shrunk, but open and closed because it was required a big operation. And we kept on taking the imatinib for another 3.5-4 years, and now tumor started growing. And then we said we'll switch to second line therapy, sudanib, and then third line. Then we took a step back and said, what do you want? What else do you want? I said, I want a second opinion. Perfect, okay. We sent them off to Birmingham, to Sam Ford, and Desai, Anand Desai. They said they're specialist surgeons in that particular area, in the abdomen. They do sarcoma surgery and complex cyst surgery, which our surgeons are a bit reluctant, understandably. But they're the specialist center for us. They did take the tumor out, but it was a big operation. It was a total gastrectomy, meaning the whole stomach was removed, part of the pancreas was removed, part of the colon was removed, the large bowel which was stuck to it, spleen was removed. It was a major, major 14-hour operation, and it was challenging for the patient. We're fingers crossed, he's now 6 weeks down the line and he's recovering, but just need to be very, very careful what you want to put yourself through. In your case, there are 2 drugs. You certainly seek a second opinion, both from the medical management point of view, meaning oncology management, and also a second knock on the surgeon's door. What is stopping you from making the surgical decision? Reason. If you can just get that around and say, yeah, I understand now why surgery is not recommended. Other thing what we have learned in the gist in the last 17 years is operating on imatinib is fairly easy. I'm not a surgeon, I'm going to say that. The thing about imatinib is imatinib does not impair wound healing. So I stop my imatinib for my patients the day before the surgery. The moment they start eating and drinking, we put them back on imatinib. We have not seen any problems. The problem is you get fibrosis, scarring around the primary tumor or the mets where tumors are stuck, and that's challenging. But imatinib does not cause any perioperative or around the time of operation problems. So we're quite comfortable with that. Where we have difficulties and where we have challenges is when the patients are sunitinib and regorafenib. These are what we call as anti-VEGF, where they block the blood supply to the tumor, and they do the same thing to the normal tissues as well. And it's a big challenge operating on these patients. You need to be off the drug for minimum 2 weeks if it's sunitinib, because the half-life of sunitinib is something like 70, 80 hours kind of thing. So you have to be 4 half-lives minimums. And then the surgeon says, yeah, now I can operate. And 2 weeks off the drug, what is the tumor going to do? Sometimes it grows. And that's the worry, because these drugs act like a brake. Take the brake off, tumors grow, and it's a catching up game. And the post-operative complications are nothing which we are worried about, because the wound healing is a problem with these drugs. So just to be very, very careful if you're going to put yourself through major surgical procedures while on the second line, third line drugs. These things may change if we go on to avapritinib, because avapritinib is a completely different type of molecule. And also there are other drugs in the pipeline which may benefit you. Other thing I would strongly recommend is go back to your oncologist and say, what is my tumor mutational status? If it hasn't been done, you want to know now. It may not change the management plan, what you're doing now. It may open up avenues in the future. So you need to go back and say, because sometimes what has happened in the past in this country is we haven't routinely been offering or testing the tumors for their mutational status. So I had the same problem 10 years ago. From 2011 onwards, every single patient in Cambridge will get has been getting a mutational analysis done automatically as a reflex kind of testing. So we have no patient now, today in 2019, who would be treated in Cambridge without the knowledge of the mutational status. We don't treat them. We don't touch them. I don't see the patient if there's no mutational analysis done. So just go back to the oncologist and say, what was my tumor? Not the CD117 kit, that kind of positive, the genetic profile of the tumor. What was the mutation inside the tumor? What was driving the tumor? We need to know that. But it won't have an impact on the decision making, what we're doing about surgery and all these things, but may have some impact on the kind of a line of drugs which may be available for you in the future.
I know. What this has emphasised is how complicated this can be, and how a second or third opinion might help. So it's worth considering. Right, who are we going to speak to now?
My question concerns specifically the observations on metastases that Adam referred to in the beginning. I was particularly interested, A, that he pointed out that most people already have mets on diagnosis. Secondly, that for people with high risk, defined as over 10 centimetres, that is right up to, I think it was about 85%, which is high. My own stomach gist, was not just big, it was massive, at 26 centimetres, so I presume that means my risk is particularly high. It's for that reason that my oncologist, when I asked her how long I would be on imatinib, said indefinitely, working on the assumption that there would be mets coming up at some stage.
Yeah.
In fact, and that sounds entirely reasonable. My diagnosis was 5.5 years ago, or 5 years ago. The surgery was 3.5 years ago. In fact, I'm fine, absolutely, still. Now, what interests me in your observations about the risk is that I had a discussion some time ago with somebody I know socially, who is not a medical specialist, not in this area, but obviously meets people with cancer from time to time. And he was saying that he was interested in my oncologist's view, because he says from his experience, if there were to be mets, they would have been seen by now, would have been made themselves visible. And I was just interested in your perception on that.
So it's certainly not the case with GISTs, and I've seen people who have been, fine for, I'm not trying to scare anyone in the audience here, fine for years, and then, after 5 or more years, a metastasis appears. And you can get that in other cancers, in bowel cancer, you can be clear for a long period of time and then something appear. The risk reduces over time. The risk of getting a metastasis is greatest towards the time of diagnosis and does obviously decrease over time. But we do see it late presentations of metastases.
Mm-hmm. I was 7 years post initial op before a metastasis was found. And I remember speaking to one patient where it was 20 years. The first tumour was removed before GIST was heard of. And then she got what was clearly a GIST after 20 years, and they went and looked at the wax block that the hospital still had of her original tumour, and it was a GIST. So I don't think, when you've had a GIST that's reasonably high risk, I don't think one can ever say, I'm cured. You can say the risks are going down and I'm going to live my life, but there's always that need to be monitored, I think, even if it's just a routine scan once a year just to check. Would you agree with that?
Again, it's very patient dependent, and it depends on the original primary, and whether there's imatinib that they've had and other medical problems, and so yes, potentially, but certainly not necessary for everybody.
No.
What's the longest the patients have been on imatinib?
Lifelong.
How many years?
Well, since
I
the
don't know.
original
You're
trial,
probably
which is in
in
what,
Okay, so
99?
the
You want a mic?
right. Okay, so
David Cook?
the KIT mutations, the gene which is the driver for the tumor, the most common gene. The mutations were discussed in 1998, and imatinib, as it was known back in that time, STA 571, was 2000. First patient was treated in 2001, and the trial, an American trial in 2002, so some patients still alive on imatinib. So the longest patients on 17 years from the American perspective. In my practice, I got patients going back to 2005, so 14 years on imatinib. And what we have learned is that in the long term, I allow the patients to make their choices about what dose they can handle, tolerate. My philosophy is based on T's, letter T, treat to tolerance, not to toxicity. Okay? You don't want the patient end up with horrible side effects. Same thing happens to sunitinib, more so with sunitinib and regorafenib, because they're quite toxic drugs. And lots of oncologists don't understand the concept of treating to tolerance, especially non-GIST specialists. You might be a good medical oncologist, but they're all chemotherapy oncologists. I don't treat sarcomas. I'm a GIST specialist. I don't touch sarcomas. There's what is called minimal effective dose, meaning a dose where there's an anti-tumor effect. And there's what is called maximum tolerated dose, MTD, which is what often the licensed schedule. Sunitinib is a good example. 50 milligrams, 4 weeks on, 2 weeks off, is the schedule which most oncologists recommend. I don't use it. I use 37.5 milligrams, continuous daily dosing, meaning every day. And then I allow the patient to make the decision when they want to come off for a few days. They're getting a bit of side effects, a bit of hand-foot syndrome, a bit of sore mouth, a bit of diarrhea, a bit of fatigue. Hemoglobin drops to from 120 to 110. Just take a few days off. Doesn't do any harm, take a few days off. And that titration, you need to empower the patient to make those decisions. And by doing that, what you do is keep the patient longer on the drug. Whereas if you just insist on taking the 50 milligrams 4 weeks, and then by third week, you're actually really in trouble because of side effects. And you get 2 weeks off because of the side effects. And then the tumor grows. So what we've learned in the last, sunitinib was approved in 2006. The trials were done in 2006, and the NICE took 3 years to approve the drug in 2009. So we got 12 years of experience with sunitinib, and we learned very quickly that there's no right dose, right schedule, and you tailor the dose to tolerance. That's the thing. The other thing with the GISTs in the primary setting, Terry was asking the question about 26 centimeters. I'm going to say size does not matter. It's what drives what is the single most important, the two important factors for predicting the risk of tumor coming back. Size is one of those things. So size, site of the tumor, and the mitotic count, number of cells trying to divide under the microscope, you can see them. One thing which has never been addressed in the GIST field, especially ourselves, is that the behavior, molecular behavior of the tumor. We have never incorporated that into the risk stratification. I'm using it routinely now in my practice. I don't say to the patient, you got a 26 centimeters tumor, mitosis 2, and then tumor site is stomach, and your risk is this. I go the extra mile to get the molecular profiling of the tumor done, use that information in my clinic so that I can explain to the patient, this is your risk. And I had a patient referred from Norwich yesterday. Small biologist, 7 centimeter tumor, big for small bowel, and the predicted risk was 24% of his tumor coming back in the next 5 years. And the patient was concerned that it's too high risk, 24%, 1 in 4 chance. And then we looked at his molecular profiling. What is the mutation driving the tumor? And then we also have a new way of looking at the mitosis, the number of cells trying to divide. They're called prognostic contour maps or heat maps. So we put all that information together. We actually worked out that his risk of relapsing, the predicted risk, is between 10 and 15%, not 24%. And I said to this is what's on the table. What do you think now? I didn't make a decision. I allowed him to make the decision. Oh, that means 85, 90% chance of not coming back. Yep, that's the thing. So do you want to be on imatinib for 3 years? He said, no. I'm quite happy to take the risk. We don't do that in breast cancer or bowel cancer. We actually give patients toxic chemotherapy for 6 months if the risk is even 5%, 3%, 4%. In GIST, we take the liberty to not to offer adjuvant, meaning after the operation imatinib, even the risk is 15%. With the knowledge that if it comes back, if you happen to be 1 in 7 patients, tumor comes back in 5 years' time or 10 years' time, if you know the mutational analysis up front, you can tell the patient that the chance of this drug working in your case could be close to 100%. And you remain on the drug forever. So that's what I did to this patient yesterday. I knew the mutational analysis, the molecular profiling of the tumor. I knew his risk was much lower than what was predicted on the stratification model. And then I knew that if his tumor comes back in the next 5-10 years, the chance of the imatinib working on his metastatic GIST is 100%. So there's no uncertainty there. So he was comfortable in not having the adjuvant imatinib now. And he said, as long as I'm scanned regularly, and then we'll. Other thing what has changed is we were looking, back in 2002 when we started my GIST practice, we were looking at big tumors, big metastases, big lumps. In my practice now, because I'm following the patients more carefully with regular imaging, regular scans and everything, we're picking up these secondaries when they're much smaller. We're taking them out. Other thing is CT scan grossly underestimates the peritoneal disease. We know that. The liver, fine, CT, MRI, and PET scan is hopeless. So if somebody's got peritoneal met, which you showed one of the, often that what you see on the CT scan, and the surgeon opens up, there'll be multiple tiny things sitting there in the peritoneum, and you don't see them on the CT scan. And that's another thing which you need to be remembering, that what you see on the CT scan may not be the whole story. Then the other thing is that if you take the big tumor out, if the small tumors have not actually developed a secondary resistance mechanism, they may be sitting there for a number of months, maybe a number of years. So that could be the possibility. So you just need to be careful. So primary GIST, if we take it out, it's look at the size, site. We'll talk about that in the afternoon when I'm giving my talk. But again, go back to this thing that we have to have the molecular profiling done. Mandatory. I think there are still centers in this country which do not routinely offer the molecular profiling. We just come back from the Genomics England meeting yesterday. The NHS England is proposing that they're starting with leukemias and sarcomas, what is called whole exome sequencing. They just sequence the whole genome. It takes a long time to get the results back, but that's what they're going to propose. We're living in an age where that information becomes part of a standard of care. We need to learn how to use that information, how to interpret the data, and also how we tell the patients and the families, because that data is gobbledygook. It really gobbledygook. And trying to say this one is what it means to you for your tumor and for your follow-up and everything. Come back to you, wild-type GIST, completely different. I think we can talk about that at a different time, because we are looking at, because wild-type GIST, we got a national clinic in Cambridge. So all the patients from UK, they come to me. We just had a clinic about 4 weeks ago. Yeah, 4 weeks ago. We got about 80, 90 plus 100 patients so far. Each wild-type GIST is different. So I hate the term wild type because it doesn't mean anything to me. But we are going to tailor the treatment to that patient. And in your case, I think, I know you very well, so there are options available. So I think, again, you have to remember you are unique individual. You may have a stomach gist, and person sitting next to you may have stomach gist, but you two guys are very different, completely different. And you may have same mutation, but again different, because the other things in the tumor which are driving the tumor are making it behave differently. So that what we call heterogeneity, meaning that they look different. It's not just size, what they look like, molecular profiling. The other things which are happening, we have not fully understood yet.
I'm just interested to know, for those patients who've currently got GIST,
Microphone, Jane.
I'll shout for now, how many of you actually know your mutational type?
Can you raise your hands,
If
please?
you do know your mutational type,
1, 2, 3, 4.
Let's have a show of those that don't know.
Somebody don't know. Quite a few.
right, that's a significant number that don't know.
Right. So what are you going to do tomorrow morning? Well, Monday morning. Find out what your mutational type is. So hang on. I'll get. By the way, this is why I call him Yoda. It's not just because of his size.
And can I just ask if you can have a definite diagnosis of a GIST on radiological appearances only?
No. The answer is no. Never use the G word without a specialist pathologist confirming the diagnosis at a regional centre.
They can say probable GIST.
Well, I've got a definite diagnosis of GIST on radiological appearances only from the MDT, and I'm having a real difficulty getting referral to a
Ask for a
specialist.
second opinion.
I have.
Where are you based?
Hull.
So you said you have. So what's happened?
Well, I asked for a second opinion, and it was an upper GI surgeon who, again, is lovely, and you know. Anyway, where would you like to go? My daughter lives in Manchester, so I said the Christie. Yes, we'll do that. Which consultant? So I said, I haven't got a list of the consultants, but, can I recommend a consultant? An ex-colleague of mine. Fine. So I went home, and he's not on the specialist list at the Christie. I think he's just a mate, and he happens to be a surgeon.
Do you know his name?
Yeah, Ian Walsh.
Ask to see Mike Leahy.
Mike Leahy is the expert geologist.
Well,
I can give you his secretary's number.
I think somebody did, and I've given the upper GI surgeon secretary her name and telephone number, and that was a month ago, and still nothing's been done.
What this has also emphasised is that we can help with this. Just Sport UK can help with this. So ring us, and we can give you the name of your local specialist.
It's only a small gist, and it's been pretty dormant for a couple of years, but they have told me it's a gist. Are there other tumours with the same appearances and
Yes.
originate?
The answer is yes.
Yeah.
We just done our 17 years audit of the what we call as the gist mimics, things which mimic gists.
Yeah.
In our database, 1 in 7 patients who were diagnosed to have gist on some kind of a scan, ultrasound, or endoscopic ultrasound, or CT, or even well, mucosa will be normal. So 1 in 7 patients have a different tumor, and the most common tumor we found is schwannoma, is one in the submucosal lesions. And then we also had run-of-the-mill stomach cancer, which was misinterpreted as a gist, and then somebody with this melanoma, which is a type of skin cancer with a lump inside. And then I prefer not to use the G word without a tissue diagnosis, meaning without a biopsy. Under the microscope, when you look at the endoscopic ultrasound, it arising from the same layer which a gist is arising. Okay, it looks like a gist, smells like a gist. Yeah, it is likely to be gist. If it's been sitting there for 2 years, perhaps it's one of these what called as a more low grade or low risk gist. In that case, there's no major panic. That's the most important thing, but you do require an opinion from a specialist multidisciplinary team and a surgeon who's got expertise.
Yeah, we'd be happy to give you a second opinion. It's not as far as Manchester.
My daughter lives
Drive
in
from
Manchester.
Hull's really easy on the M62.
I think patients often, they are told you've got a gist and it's this big and go away. And the patient, of course, Googles gist and panics and phones us up and says, can you tell me something? I don't know who to ask. And I think it's most unfair of the doctors to leave a patient in this situation. And if the gist is very small, as Ramesh has just said, and it's stable, it hasn't changed for a couple of years, it'll probably not change for the next 20 years, and you can go away and live and not worry about it.
But it's also, sorry to interrupt, it's also ulcerated, whatever it is. Right. And I'm, you know.
So it's causing anemia.
You need a second opinion.
You need a second
You
opinion.
need a second opinion.
Yes.
I mean, obviously, what you're describing has been apparent for many years, and for many years, the specialists in GIST and sarcoma have been working to try and make a more standard protocol for how patients, who should be dealing with patients, which is why quite recently, earlier on this year, they actually launched the National Sarcoma Service Specification, which was announced on our website. There's a link to it, you can go and read it. And it does specify which centres are the specialist centres that you should be referred to. So, you know, use that information to back up. Yeah, so the Christie definitely is one, you know, so, you know, and if your daughter lives there, but obviously you've had a lovely offer here from the local guys as well, so, you know, it's your choice, really. But rotational analysis, I mean, we went on about this in our last meeting in Birmingham. You know, if you've got a gist, you know, in your body, and you've, you know, had a biopsy or an operation in the past, some of that tissue will have been kept in the hospital where you had your operation, and if rotational analysis hasn't been done, it can be done on that tissue, and you should request it, because as time goes on and more medications become available to target different types of GIST, then, you know, should you be relevant to one of those. I mean, we had a man call us a couple of years ago, and he was very anxious because he'd been told he had a type of GIST that was not responsive to imatinib. It was a type called a PDG-FRA D824B. And he was very anxious because he wasn't being given imatinib, and he'd read that was obviously the first line treatment, but it just so happened at the time that I was aware that they'd opened up the trial, the blue trial at the Marsden. So we advised him, get a second opinion, go to the Marsden, because you will be able to access that trial undoubtedly, because you're exactly the right candidate for the drug they're trying to test. And that's what happened. So it is worthwhile knowing what time you are.
If in doubt, contact us. We can help. With a question. Well,
we're not surgeons, though.
This is a follow-on question, really. I had a biopsy when I was originally diagnosed in 2010 that was sent to Birmingham for mutational testing. The results came back that it was KIT positive, so it was a GIST. I was told the mitotic rate was low, but they couldn't tell the genetic mutation because there wasn't sufficient genetic material in the sample. And that's why I don't know. So what can be done about that at this stage?
who's going to answer that one?
Okay. I can't say. What's your name again? Sue, hi. Where was the tumor?
I still have it. It was inoperable. It's in the peritoneum.
Right. Okay. Is it causing any problems at the moment? Symptoms-wise, and what I mean, any symptoms which you think are linked to the...
I suffer chronic anemia.
Right, okay. And has the tumor grown at all in the last 7, 8 years?
No.
Right.
It has ruptured.
Right. Okay.
several years ago.
Right.
And I became transfusion dependent.
Right.
That's now resolved. But
Okay. Was it definitely a gist? I'm just throwing it into the. I get slightly paranoid when people say to me that they've been diagnosed with a gist, but there was not enough tissue for further testing, and the tumor has been sitting there for long. Because there's one type of gist which can be quite indolent, meaning can
Lazy.
remain.
Slow growing.
So slow growing or not growing at all. It is one of those which Jane has mentioned, D842V, the PDGF alpha gist, which does not respond to the conventional tablets we use, the imatinibs and sunitinibs. But if that is the type of gist, there are 2 new drugs available. One of the drugs is really, really promising. So
where's the trial?
the trial is in Marsden. Where do you live?
Between Leicester and Peterborough.
Right. Whereabouts? Stamford?
Uppingham.
Uppingham. I know very well. Nice pub. No, my life revolves around pubs and cricket, so cricket and pubs. Apart from the gist, I mean, no, seriously, I think my catchment area goes all the way up to Lincolnshire, so we are happy to review the situation if you want to have an opinion, because there's a number of years ago, and we could make an informed decision about what should be the next step. Whether we leave it alone because it hasn't done anything, which is perfectly reasonable, or whether we need to do something beyond what we're doing right now.
Thank you.
Right, we've got about 5 minutes. So, any more questions? We'll start here, and then we'll go there.
Thank you. I don't know whether you can actually explain this because you're not a pathologist, as you said, but
Can you hold the microphone up a bit?
there. I've got a pelvic gist, exon 11 mutation. The ultrasound guided biopsy was a gist, 9 mitoses, stroke 50 HPF. I have no idea what that means. Please. Should I be very worried?
I think Ramesh might know.
Yeah.
Ask Yoda.
Who'd have thought Yoda likes cricket?
First thing, it tells you that it's definitely a gist. So we're not talking of some other cancer. And the way we look at gist is, as I said, we look at the size of the tumor and where it's arising from. If it's a pelvic gist, could be what we call sigmoid, which is the part of the large bowel, or could be a small bowel bit hanging into the... Yeah, small bowel, more likely it is, yeah. So it's a small bowel gist, 9 centimeter tumor. Was it 9 centimeters tumor?
How big?
Size matters, remember.
7 centimeters.
7.
Okay. So the single most important thing there is the mitosis. What are mitosis? Which are the cells trying to divide, which the pathologist can see under the microscope. And when you say HPF, it's high power field, meaning the eyepieces they have in the microscope, and each field is called a high power field at the magnification of, I think, around 100, I think. But we've moved away from that. We count a square area of 5 millimeters square. So if you got 9 mitoses per 50 high power field in the old-fashioned microscope, there are a lot of mitoses. That's what it means. That means the tumor is likely to be aggressive. And it's got a KIT exon 11 mutation. We want to know what type of mutation it is, but not right now, but that's another information I need. It's not just enough to say that there's a mutation in the KIT exon 11. The way I explain to my patients is, if you imagine a train, engine, compartments, and seats, okay? We think the engine is where the driver is going to be. In GIST, you got 2 genes, 2 separate trains, KIT and PDGF alpha. And in the gene, you have something called exons, which are compartments. So if you imagine I came on a train today, there was 12 compartments. So same thing happens in the KIT gene. There's something like close to about 18 or 20 compartments. And the driver for that KIT tumor gene could be sitting in any of those compartments. And the most common is compartment number 11, which is exon 11. So it's not in the front compartment engine. The driver driving the tumor is sitting in compartment 11, And then you have to work out what seat in that compartment. The seat would be from 1 to 500 and something. So you need to work out which seat in that compartment is driving the tumor. So that also gives the extra information on how aggressive this tumor is going to be. And based on the information you have, small bowel tumor size is more than 5 centimeters and the mitosis is 9. You're automatically in what we call as a high risk category for the risk of tumor coming back in the next 5-10 years. And the strong recommendation is she should be on imatinib. Okay. Okay. Important thing to remember, treat to tolerance. If you can't handle 400, stay on 300. Okay, don't push yourself to 400 because you get side effects and stop the drug. If you really want to know whether 300 is adequate for you, there are testing facilities available in this country where you can send a blood sample and check your imatinib levels in the blood. Are you getting enough imatinib or are you getting too much imatinib? That may be perhaps the reason why you can't handle the drug. Each person handles the drug differently. One thing, remember, what we call as the pharmacogenomics, I mean, the way that we are made up with different genes, how they handle the drug is different, and also different on what other medications you're taking. Are you taking any other medications? Omeprazole, lansoprazole? No. There are other medications which change the way the body handles the drug, both imatinib, sunitinib, regorafenib. So the GIST support UK leaflet will tell you which drug you have to be very careful about when you're taking imatinib, sunitinib, regorafenib. And each individual patient, you just have to work out what the dose is right for you. Is 300 milligrams or 400 milligrams. I prefer not to go down the route unless there is significant toxicity, significant side effects. There are patients of mine who are on 200 milligrams a day. You've been there for 7-8 years. They got GIST is completely stable. The metastatic GIST, meaning they got spread already. For him, that was the right dose, and luckily the mutation was a sensitive mutation. In your case, with the small bowel GIST, with exon 11, need to know what mutation it is, but exon 11, I want to be on a dose close to 400, as close to 400 as possible. Once you get down to 200 and 100, you're probably losing some benefits. I would be less likely to recommend that.
Right, we're nearly at lunch, so we've got one more question here, and then we'll break for lunch. There'll be more time this afternoon for more questions, so we'll just do this one.
I just have a question for Adam. If a patient has tumours in its liver and they're deemed cystic, would that be more easy to remove than if they were, say, live?
When liver metastases are treated with imatinib or some of the other therapies, they can become cystic, which essentially means just filled with fluid. And that can be a sign that they've actually responded and are essentially, dead or very inactive. So you certainly don't need to treat cystic metastases if they're not changing. And so if you've had metastases and they've been treated and what you're left is with a cyst, if that's stable, then no, that wouldn't be an indication for going in and operating. If they were to start growing or the size of the cyst were to start changing, then that might be a different matter. And you can see that in primary GISTs as well that have been treated with an imatinib, where you have a big lesion and part of it becomes cystic because it's died away. And it can make interpreting CT scans difficult because you can have bits of a primary GIST, for example, that are looking smaller and other bits that might be growing a bit. And it's another reason why you need your CT scans looked at by people who are looking at GIST scans a lot, because it's not necessarily straightforward and the whole tumour doesn't necessarily behave the same way. And even in our MDT with our experts, it can be a bit of a question as to whether this tumour is growing or not, or is it just changing texture a bit.
Will a cystic just shrink with time?
Not necessarily. I mean, some of that fluid can be absorbed, and it may shrink. It may shrink with time.